I am Dr. Sharjeel and you are watching my YouTube channel. Now in this challenging case, I showed you how to inject intravitreal anti-VEGF or any injection. Now at the end of this video you will be able to know what are the steps of intravitreal injections into the eye, how to avoid endophthalmitis while performing intravitreal injections into the eye, and what are the complications common and rare while performing intravitreal injections, and how to make diluted povidone iodine for intravitreal injections. So let's start. Now it looks very easy and simple method, but have grave consequences if you don't perform under aseptic situation, because it is associated with the grave complication of endophthalmitis. So in this video I have tried to show you the best possible technique or my technique to decrease the incidence of endophthalmitis. Endophthalmitis is a rare complication. You can also cause other rare complications like retinal detachment, central retinal artery occlusion. Common complications are discomfort while inserting the needle, subconjunctival hemorrhage, bleb formation with vitreous reflux, and transient elevation of intraocular pressure. But our main goal is to avoid endophthalmitis. Now, intravitreal injections can be performed in office as well as in operation theatre. Studies says that chances of endophthalmitis are less while performing it in operation theatre. So I prefer OT instead of office. And studies have also proved that outbreaks of endophthalmitis were more associated with pharmacological compounding procedures used to prepare the syringes containing the drugs rather than drug or injection technique. Now it can be performed with or without eyelid speculum. Patient should be comfortably lying, put topical anesthetic drop, paint and drape. 10% in our country, 10% commercially available preparation of povidone iodine is present, and literature says that make it 5% by diluting it with distilled water and use it. But in my technique I prefer more diluted povidone iodine. Like I take 1 ml of 10% ready-made solution and put 4 ml distilled water to make it 2%. Literature also says that more diluted pyodine is more potent and less toxic to the cornea and conjunctiva. Then you can perform with or without eyelid speculum. I use eyelid speculum to avoid needle contamination by the lashes via involuntary reflex lid closure during needle entry. You can also apply mask or without mask, but studies have shown that the incidence is equal with or without mask. So it's your personal choice. So you should perform under sterile conditions. You should have a topical anesthetic proparacaine. You should have povidone iodine. You should have pair of sterile gloves. The OT should be well cleaned and sterile, and minimal personnel should be there. Remove the unnecessary personnel. Then identify the status of the eye, whether it is phakic, pseudophakic or aphakic, because then you have to mark the pars plana. In phakic it is 4 millimeter from the limbus, in pseudophakic 3.5 millimeter from the limbus, and in aphakic 3 millimeter from the limbus. Then with a large bore needle like 18 to 20 gauge, you draw the medicine into 1 ml needle and then change the needle to 27 to 30 gauge, because large bore needles cause greater vitreous reflux in comparison to small bore needles. And then put 0.05 ml intravitreally with needle pointing center of the vitreous, and don't come out of the globe immediately. Take 5 to 10 seconds. You can squeeze the conjunctiva around the needle with suture tire to stop the vitreous reflex. Now once again at the end I would like to tell you the steps of procedure. Now step 1 is that the patient should be lying comfortably in supine position. Step 2 is that confirm the actual patient by asking his name, his patient ID, and confirm which eye to be injected and tally it to the notes. The third step is that draw up the medication in 1 ml syringe and then exchange the needle with 27 or 30 gauge needle. Then put 1 drop of topical anesthetic, proparacaine. I prefer just topical anesthetic, but some doctors prefer to inject 0.5 ml xylocaine solution subconjunctivally at injection site as well. Then at the time of injection, try to remove the extra personnel from the room and ask the patient not to speak during procedure. Put 2%. You can also use the traditional 5%, but I put 2% povidone iodine into the eye. Then put on sterile gloves, insert the lid speculum, drench the conjunctiva again with 2% povidone iodine, again put topical anesthetic drop, mark the injection site with caliper, inject into the globe aiming center of the eye. The entry should be smooth and gradual at pars plana. Apply suture tire or cotton tipped applicator to avoid vitreous reflex. Put again 1 drop of 2% povidone iodine. Remove the eyelid speculum. So these are the steps, and I have also told you the complications. The dreadful is endophthalmitis, and the others are retinal detachment, which is also rare. The common are subconjunctival hemorrhage, pain, bleb formation, and transient elevation of intraocular pressure, and sometimes central retinal artery occlusion as well. So I hope now it is clear that how we should inject intravitreal into the eye. Thank you very much.